Hi, my name is Ray Mak. I'm a radiation oncologist, and that's a medical doctor that specializes in delivering radiation treatment for cancers. And I'm going to give you a little bit of a background on lung cancer and tumor delineation for this upcoming Topcoder challenge. As an overview, I'll start a little bit with talking about lung cancer in general as the problem, talk about potential lung cancer treatments out there. Next, we'll move on to talk about what exactly is radiation therapy and how do we delineate lung cancers to plan radiation therapy. And then we'll look at some case examples of how humans delineate these tumors. So first, the problem, lung cancer. So as many of you may know, lung cancer is the second most common cancer in both men and women in the United States. These are 2016 statistics. But is the #1 cause of cancer deaths among both men and women, accounting for almost more than 25% of cancer deaths in 2016. And for our international friends out there, just so you don't think this is an American problem, this is some statistics from 2012 looking at the world. And this has clearly become an international health crisis with over 1.8 million people diagnosed with lung cancer and 1.6 million people dying of lung cancer in 2012. In terms of treatments, we've been slowly making progress over the last couple of decades with advances in prevention, screening, and treatment approaches that have slowly improved outcomes, increasing the chances of cure. But as you can tell, the outcomes still aren't great. Some of these treatment options include radiation therapy, surgery, chemotherapy, immunotherapy, and some genetically targeted therapies. We're going to focus on radiation therapy for the purposes of this contest. So radiation therapy is a very important part of treatment for lung cancer and has the potential to cure many of the patients that we treat. Some of the challenges that we face with radiation therapy and lung cancer is that it's estimated about 64 to 75% of lung cancer patients should receive and would actually benefit from radiation therapy around the world. However, internationally, we estimate that only about 25 to 50% of these patients actually receive the radiation therapy. And that leads us to question why. Why is this important treatment not available to many of these patients around the world? And I think some of the things that people have thrown out there is that radiation therapy is both complicated and a very resource and time-intensive treatment, as I'll show you in a moment. And there's a significant knowledge and training gaps around the world, and we'll talk a little bit more about these problems as to why we're approaching Topcoder with this challenge. So next, as a brief background, I'm going to talk a bit about what actually is radiation therapy. So first, to answer that question, we have to ask, what is radiation? So radiation is a form of high-energy photons. It's on the light spectrum. Typically, we use low-energy X-rays for diagnostic scans. So if you get like a CAT scan, that's using low-energy X-rays. In medicine, we use much higher energy, more penetrating X-rays for cancer treatment, and that's the kind of radiation we're going to talk about more. In terms of the history of radiation therapy, you know, the ionizing radiation was discovered in the 1800s, and it didn't take long for doctors to start applying this newfound energy to treating cancer. In the 1920s, 1950s, some of these early devices were used to treat cancers with pretty primitive approaches. Until the 50s and 60s, into the modern era, we've developed new machines called linear accelerators that can deliver beams of radiation into the patient to treat small tumors within their bodies. And so what these devices look like are essentially there's a treatment head where the radiation beam is emitted, and the whole treatment head rotates around the patient on a rotating gantry. And then the patient is typically positioned on a robotic couch to be able to move the patient through 6 degrees of freedom to position them precisely to aim the radiation at the tumor. And so how does this all work? How do we use radiation to treat cancer? Radiation in its own right is not a smart treatment in the sense that it can kill cancer cells through damaging the cancer cell's DNA, but it can also damage the DNA of your normal cells and the normal organs and damage those organs. In medicine, we use the radiation by focusing the beams of radiation to concentrate the radiation dose on the targeted tumors, so thereby minimizing injury to the surrounding organs. And I'll show you what that looks like. So if you imagine the tumor as a simplified round ball within a patient, and here's a representation of you can see of a person, a real live person, with this red thing being the tumor within the patient in the lung right next to the heart, and the patient's lying on this table. If you bring radiation sources, beams of radiation from multiple different angles, aimed and concentrated on the tumor, so that each beam hits the tumor, but on its way through to the tumor, it still passes through normal organs and exits out the other side. But because all the beams crisscross and intersect on the tumor itself, we're able to concentrate the radiation dose around the tumor to deliver doses that can hopefully eradicate the cancer cells there while minimizing the radiation to the surrounding organs. And effectively, the modern linear accelerators of these radiation treatment delivery devices are essentially this exact scenario where we have the emitting source of radiation, the head machine, rotating from position to position around the patient, delivering a beam of energy as shown in this radiation plan for this patient, and with all the beams intersecting on the tumor that concentrate the radiation dose in that area. So the hallmarks of modern radiation treatment include precision targeting in lung tumors. So first off, we have to position the patient in the exact right location so we can hit them precisely with these beams of radiation every day. Secondly, we need to accurately delineate the tumor on medical imaging so that we can target the right location and not target the surrounding normal organs. And third, we need to be able to deliver the radiation as promised in a very pinpoint fashion, and we're typically able to do this within 1 to 5 millimeters. So we have one handled, we have 3 handled with our modern technology. Our big problem right now is 2, and that's making sure we're accurate and consistent in delineating the tumor to make sure we're targeting the right location. And that's where hopefully the Topcoder's contestants can help us with this problem. So third, let's take a look at what's the state of the art currently of how do we delineate lung cancer tumors for radiation therapy using mostly manual approaches. So the way we plan these cases, how we delineate the tumor, is by first obtaining a medical image, typically a computed tomography or CT or CAT scan. These are X-ray based images acquired using a helical scanner that generates, and this is sort of, for people that have seen it, it looks like a donut. The patient's positioned on a table, and they are basically on a table that puts them through the donut, and there's a helical scanner within the donut itself. And this generates multiple 2-dimensional cross-sectional slices of the patient, which then can be used to reconstruct a 3-dimensional image. So essentially you end up with a stack of images of slices through the patient, imaging the organs at each of those levels. And once you have that stack of images, you can reconstruct it into a 3-dimensional patient model, as shown here. So how do we delineate the tumors once we have these images? So what happens is the doctors, such as myself, will examine the CT images slice by slice. And with some software tools that we use in the clinic, we'll essentially draw or delineate the grossly visible tumor, as shown here with the red line, which is the target. And then we'll typically also draw a safety zone around the tumor of where there may be cancer spread that we can't see even with the best CAT scan we have. And then we'll also draw out adjacent normal organs, as shown here. We've drawn out the lung and organs like the esophagus that are in the chest. Typically, one of these cases, if we do it manually, an average doctor that specializes in this kind of treatment may take about 30 to 60 minutes to do a case from start to finish, to delineate all the tumors and the adjacent organs. And so what are we using in the human's brain as we kind of interpret these images and make these what we call contours or drawings or delineations? And basically, both consciously and unconsciously, we're integrating multiple knowledge streams, including a general understanding of normal human anatomy in 3 dimensions, and then some experience-based knowledge of what the appearance of normal anatomy in lung tumors should be on CT scans. And some of the visual cues we're looking for is we're looking for things like left-right asymmetry as we go through the body. We're looking for density differences, textural differences essentially between things that may be more dense, such as the bone, versus the least dense, like the air, and with tumors and other soft tissues like the muscles having an intermediate density. And we're really looking for those slight variations in grayscale to identify the tumor. The initial training period to develop basic competency to delineate these tumors as a radiation oncologist takes about 10 years, and you could argue that to develop true expertise may take somewhere around more like 15 to 20 years. And this gives you a sense of what we're actually doing. Like what are we trying to do with delineating the tumor on the CAT scan? So this image here is actually a lung from a patient that was removed via surgery, and they cut open the lung, and within the lung you see this tan looking structure, and that's actually a lung cancer. And it's embedded within all this healthy normal tissue, which is the normal lung. And when you look at this, the CAT scan that was done before the patient went to surgery, this is what you see, and that's the tumor that's in gray, and in black is the normal lung tissue, and that corresponds to what they took out with surgery. So you can think of radiation treatments as sort of analogous to surgery. Instead of cutting out the tumor, we're basically delivering beams of radiation at the tumor to kill it. And so to be able to do that, we basically need to reconstruct the exact location of the tumor within the lung based on the best imaging we have, which is the CAT scan, outline the extent of the tumor that we see on the CAT scan, and deliver the radiation at this target to basically destroy this zone of tissue. And we have a bunch of fancy acronyms for this, and basically the region that the tumor that we can see grossly on the CAT scan is called the gross tumor volume, and then we usually, as I mentioned earlier, provide some safety margins to treat cancer that we can't see, that's microscopic, meaning it can only be seen under a microscope and not on the CAT scan itself. And then we'll put a uncertainty margin for daily setup error, which is usually that couple of millimeters, and that's the area we actually deliver the radiation to. But for the purposes of this contest, what we're really looking for is that first step, which is to draw the gross tumor, the tumor that we can see distinctly on the scan itself, the gross tumor volume, or GTV, and that's really the core part of what the radiation oncologist does. So this is an example of what that looks like. Here we have an axial image, and we'll show more of these in the couple of case examples that I'll show later. But again, the gross tumor volume is the core area where of the tumor that we can see on the CAT scan, and then these additional margins are basically sort of additional safety margins to make sure we deliver the radiation to the right area. And I do want to make the point that, some people often think of lung cancers as little balls, or, just a little thing that's floating, a nodule floating in the lung itself. And that's certainly true. There are some small, round lung cancers, but in general, tumors are pretty heterogeneous, meaning they're as different as people. So here's 4 different lung cancers that have been manually segmented, manually delineated by a physician. And you can see a representative axial slice shown here, meaning a slice through the patient in this plane. And you can see that in each of these 4 patients, the tumor shapes are very different, both in shape and in appearance. And when you look at the 3-dimensional reconstruction, so this is taking all the slices of the tumor that were drawn, you can see how distinct they are between these 4 patients, from a very large round oval mass to something that has 2 discrete areas, something that's very highly irregular, or what we call spiculated. And you can also see from these reconstructed 3-dimensional depictions is that there's artifacts present both from the scan itself and from the human delineation process. Again, these are manual approaches. You can see that there's little inconsistencies here from slice to slice, because essentially they drew on each axial slice and then basically stack them all together after the fact. And I'll show you what that looks like in a moment. And then once the tumor is drawn, we also draw some of the organs in the area, like the esophagus, spinal cord, the lungs, This will not be the subject of this challenge, but I include this as a potential avenue of understanding what normal anatomy looks like compared to what abnormal findings such as lung cancers appear within the human body on these medical images. So why is this important? Why do we have to be really accurate at delineating these tumors? Why can't we just draw, a rough shape in the ballpark and call it good? The main point is because we really are taking aim when we delineate these tumors. So when we plan radiation treatments, what we're actually doing is shaping our radiation treatment beams to fit the tumor as we've drawn it, as we've delineated it precisely. So we will shape each radiation beam. So here's an example of a segmented lung tumor, and you can see in yellow the actual portal, the actual shape of the radiation beam that we're going to fire from via beam 1 through the patient, and it's shaped precisely so what we've drawn on each of those CT slices. And we'll bring in a second beam from a different angle that again corresponds exactly to the shape of the tumor. A third beam, multiple beams will be brought in to basically concentrate the radiation dose in that area. And here's multiple other examples of different ways to bring in beams to concentrate the dose on the tumor. But if any part of the tumor is not delineated, so if, from this example here, if there's a piece of the tumor out here, if it's not delineated, we don't treat it. We don't deliver radiation to that area, and that region of the cancer is basically will continue to grow because no treatment has been delivered to it. And it gets easy to kind of look at these drawings and segmentations and kind of lose touch with what you're doing when you're just looking at a computer screen all day. And there are real consequences to missing in what we do. And when we miss any part of the tumor, that part of the tumor will grow, and we usually only have one chance of getting it right. So if we miss, the cancer comes back, and options are often limited at that point, and the patient dies, unfortunately, quite frequently from the lung cancer, as you saw from the statistics I showed you earlier. And this is a picture of what it looks like to die from lung cancer from our friends at Health Canada. So that gives you a sense of why we need to get this right. Just to give you a little bit of background of how we then sort of carry out the next steps, and it's more just for informational purposes so you can get a sense of what happens after we hopefully get the tumor delineation right, is that the patient gets positioned under the radiation treatment delivery device, the linear accelerator. On the table, it looks like that. The machine has imaging arms, which allow us to take more x-rays, more pictures, to make sure we line up to the right spot, to hit the spot that we've delineated. And then the business end of the machine, the treatment beam, comes out of the top. And this whole thing, as I mentioned, rotates around the patient to deliver multiple beams of radiation, all pinpointed on the areas that we've delineated. And this is a real live example of what it looks like. So this is in a cartoon here on the right. These are cartoons, of course, on the left. But this is actually a patient's real live lung tumor as we deliver the radiation beam into them to hit this little nodule. And again, we've fortunately drawn it right. We are aiming at the right location in the tumor. We can actually see it, and that's this gray thing here with the lung tissue in black around it, moving in and out of the radiation portal as we deliver the radiation beam. So what are some of the challenges we face with this current sort of state-of-the-art of radiation oncology, where we do these manual tumor delineations to develop a target that we then aim the radiation at? Some of the big problems are, one, ensuring adequate quality. So there's a huge degree of variation between doctors on the same patient, and that's been shown time after time in multiple different cancers. Even within one doctor, on one case, there's often inaccuracies and inconsistencies. And for someone like me who's had 10 years of training, 5 years of experience, I still, even when I look at my own cases, will find inconsistencies from slice to slice. And that's purely a product of our human limitations, in the sense that when we're trying to interpret these very complex three-dimensional structures, there's certainly some amount of data overload, and being able to track every single last corner, every single last piece of the tumor. There's certainly limits to the human eye in terms of what we can interpret, the human eye and the human brain, I should say, in grayscale detection, so determining slight texture differences between one area of the scan versus the next. And there's a steep learning curve. It requires a lot of experience to get a comfort level and expertise at making sure that you're defining the tumor in the right location. And lastly, because of all these limitations, there's an access to care problem in the sense that these are very time-consuming, human resource-intensive treatments, and it basically puts doctors behind the computer screen for hours at a time when that time could really be better spent interacting with the patient directly. So what's the solution? And I think really what we need your help with is developing a better automated tools to delineate lung tumors so that we can make manual delineation of lung tumors an obsolete thing of the last century. And I'm happy to make this become obsolete for this part of what I do in my job, because really my goal is to be in front of the patients again instead of behind a computer screen trying to find these lung tumors and delineate them. And I think overall, if in general, our hope is that automated solutions will improve our accuracy and efficiency. It will improve our quality of care and access to care for lung cancer patients receiving radiation therapy around the world, and certainly, hopefully, cure more patients out there. So lastly, I want to take you guys through some case examples of how we do this tumor delineation manually, and I'll switch to a different software in 1 second. And the goals of these case examples are to give you an orientation to CT scans and normal anatomy. We'll also look at some tumor characteristics, imaging features. We'll look at how tumor delineation is performed in practice, and then provide some special case examples. Certainly, we can't give you the training to do this manually or give you the medical background to do this, but we just want to give you a sense of the human approach to give you a sense of some of the factors we put into it, since that may help with your coding. So what I've pulled up here is a software that we use in the clinic to manually delineate lung tumors. And what we're showing here is a DICOM image of a CAT scan for a single patient. And as I mentioned earlier in the PowerPoint presentation, a CAT scan involves obtaining multiple X-ray based images that are sort of slices that are stacked on each other to generate a three-dimensional image. And in this case, what we can see here is what we call the axial plane. So this is a slice through the patient, and this gives you the sagittal and the coronal planes, and it gives you a sense of the level that we're looking at. So at this slice, we're cutting through the patient at this level, which is just at the base of the neck. The A stands for anterior, so this is the front. Patient's facing this way. The P stands for posterior, that's the back. So the patient's back is here. They're lying on a table when when the scan is obtained. R is right, L is left. And on this slice at the base of the neck, what we see is all the anatomy of the patient at this level. And these are 2.5 millimeter slices. So what we see here is a combination of different organs. So to orient you to CAT scans, the image provides you with a grayscale images that are basically density dependent. So white, which is essentially the highest attenuation of these X-rays, is essentially bone. These are the highest density materials. The black area is the lungs, because they're less dense areas. And this black thing in the middle is the main airway, the trachea. So the way we interpret these images is we typically are trained to kind of go slice by slice. So we are now heading downward toward the feet of the patient. So this is the chin, the head's up here, and the feet are down here. So we're basically going to move from the top toward the bottom now. And so each slice as we move is visualized by the doctor. And what the doctor is doing is basically looking left to right, trying to compare any asymmetries, and also in the back of their minds they have a mental map of what normal anatomy looks like. And this all looks normal so far. We have the top of the right lung here, the top of the left lung. We have the white back here is the spine. We have some ribs on the front. This white thing here is the sternum. And this gray stuff on the sides are the muscles, and the black is the less dense fat, which is slightly more dense than the black air in the lungs and in the airway. In the center part of the chest, there's a bunch of blood vessels, and that's what we call the mediastinum. And as we move down, everything looks normal so far. Looks normal. And just right about now, we see the tip of something abnormal. I'll give you guys a moment to see if you can find it. And for those of you who are paying attention, this area here, if you look right to left, looks slightly abnormal. And you know, the density of it has a similar gray appearance to the muscle. So we know that it's not air, it's not black. We know it's not bone, it's not white. It's somewhere in between. And that's usually what the doctor is looking for when they're looking at these scans. And as we come down, it becomes a little bit more obvious that there is something abnormal here. And that's the lung tumor in this case. And as you come down, you can see again that this is actually a relatively large tumor that's in the lung, but growing up against the muscles, and this white thing here are the ribs, growing into the patient's ribs and the muscles of his or her back. And as we interpret these images, what the doctor is looking at is the density. So we can see, you know, that when I click here, it gives us 33 Hounsfield units. That's a measure of density. And we're looking at a window and level that's called the soft tissue window, which you can see the window level units here. And basically, we kind of toggle between different window and level settings to get a better sense of the interface, the boundaries of the tumor between the lung tissue and then between the muscle tissue and ribs over here. And you can get a sense we can manually adjust it as well to change the grayscale so that we can get better contrast so that we can really find that border of where the tumor is. And so just switch back to the soft tissue window. And so practically what we do to delineate these tumors is essentially we have a number of tools such as paintbrushes to kind of identify the edges of the tumor. And this is just a rough drawing, which we can fine-tune after. So that's, and then we basically would do this slice by slice to fully encompass the tumor as the target for our radiation therapy. And this is the sort of the final product that we have for this case. And some things that I'd like to point out here is that if you sort of look at the grayness of this, it's actually pretty hard to tell between the muscle nearby, and this is the muscle back here, this is the muscle of the shoulder blade. It's actually pretty hard to tell this gray versus that gray versus the gray of this big thing here, which is the aorta, one of the big blood vessels in the chest. But what you can do is what we do typically is kind of adjust that window and level setting here a little bit, and you can start to see that the gray scale, even though it's subtle, there are differences between this tumor, the cancer, and the adjacent muscle. And you know, some people eloquently describe this as the evil gray, the sort of dark, heterogeneous gray of the tumor, that it's distinct from the grays of the soft tissue, of normal soft tissue like the muscles. And that's something that we're looking for when we're contouring these cases. And then lastly, what I want to point out are some of the normal organs here. So, again, the tumors often grow within or adjacent to normal organs. In this case, in blue and orange are the right and left lungs. You can see this lung cancer did arise from the right lung itself. The heart in this case was also drawn as shown here. And basically, the point of illustrating this to you is that as the radiation oncologist, as the human operator goes through these cases, what they're doing is creating a mental map or registering this patient's anatomy to a mental map of multiple cases the doctor's seen in the past of where are the normal anatomies, where are the airways, where are the blood vessels, where are the heart, lungs, and esophagus, where are all those organs, and what is new, what does not belong. And in this case, what jumps out is this gray thing that does not belong when I register this to all the normal lungs that I've seen in the past, and also when I compare against the opposite side. So that's contouring and looking at interpreting CT scans from the radiation oncologist perspective in a nutshell. So I want to move on to the next case. Again, we are scrolling through the patient, and we're just starting again at the top near the neck. And as we come down through the chest, you can see we're scrolling down based on this image on the right here. So as we're scrolling down, the one thing that I would point out on this case that's different from the first case that we looked at is that in this case, you see that there's some white, some high density material in the center part of the chest and the mediastinum that is different from before. And if you look at this white is almost as dense as bone. And what that is actually a contrast agent, a dye that we injected into the bloodstream of the patient that's temporarily circulating through the bloodstream. That's a high density material. And that high density material artificially creates contrast of the blood vessels, so you can more distinctly see these blood vessels relative to tumors or other surrounding organs. And so this is not a natural occurrence. This is a medical intervention that has changed the characteristics and the property of the scan by introducing a high density material into the bloodstream. And so because that it can definitely impact how we manually contour, delineate these tumors, we will provide you with the clinical information on each patient, whether or not they receive the contrast material in their bloodstream, so that you can also account for it in your programming. And in this case, the reason why there was contrast added was because there happened to be a very small tumor that was adjacent to a blood vessel, so we needed that better contrast between the tumor and the adjacent blood vessel. And if anybody's seen it so far, they can feel good about seeing a lung tumor, being able to identify it, but this is a pretty subtle one. And again, we're looking for asymmetry, right to left. We're looking for the evil gray, the gray that's different from the surrounding normal organ. And where we have it, it's right about there. So that is an example of how we use contrast to better identify lung tumors. I'm just going to take a pause here to find the next case, actually. All right, last case. So this, again, is another patient with a lung cancer, and we're, again, starting at near the top of, here's the chin, we're sort of starting at the base of the neck, and we're going to scroll down through them slice by slice again, from chin down to toward the feet. And again, we're looking for right to left asymmetry is how we do it manually. There's nothing asymmetric here. The lungs are black. This patient was another patient that received the contrast material in their bloodstream, so you can see that there's high density material within their blood vessels. And what's coming through, we do see something asymmetric here compared to the other side. That's not part of the normal anatomy, and it's actually not in the lung tissue itself, so it's not actually truly a lung tumor. What it is actually a lymph node, an area where the cancer spread from within the lung tissue into these normal glands within the center part of the chest. And for the purposes of this contest, we're not actually looking for you to delineate these areas. These structures have been delineated as part of the normal radiation planning approach, mainly because we do have to treat these areas, but for the purposes of this contest, they're really there for informational purposes only. And what we're really looking for is the ability to identify the lung tumor itself, which is in this case shown here. And again, you can see this one is a relatively small lung tumor within the lung, the right lung here. And the actual bulk of the cancer is actually in the lymph nodes itself over here. But we wanted to give you an example of this case, this kind of situation, so that you would not be confused when you're looking at the structure set. So again, the lung tissue, the lung tumor within the lung tissue itself, for the purpose of the challenge, what you're trying to recreate, what you're trying to delineate, is the radiomics GTV, whereas the radiomics LN sum, which just means the lymph node sum, are areas of these lymph node, these glands, where there's cancer involvement that were drawn separately, but not the actual purpose, not actually for the purposes of this specific contest. But it does give you a sense that the cancer, the appearance of cancer, is actually unique and different from the surrounding normal organs. And there may be similarities between these lymph node delineations that have tumor within it and the primary lung tumor itself. And in many ways, when we're drawing when the doctor is looking at these cases to draw out where the tumor is, we're actually looking for both anything that looks abnormal in the sense that it has that textural gray, evil gray appearance, whether it's in a lymph node or a tumor. But for the sake of simplicity, we're going to focus on getting the lung tumor right for now. I look forward to seeing what you guys put together, and we'll also answer your questions in an upcoming group session as well.